Hello, everyone. Welcome and thank you for joining us. Apologies for eating into your evening, but I do want to thank you for taking the time to join us. I know not everyone could, and for that we are recording this session now, and it will be available later on the web, probably with a streaming format, and we'll be posting that for those who, again, who weren't able to make it. I'm joined here by Dean Lucy and Dean Hauer. Before we get started, I would like to hand it over to Dean Lucy for some introductory comments.
Thank you, Dean Davis, and hello to all of you. I'm very happy that you took the time to join this town hall, and I'm only sorry that we can't be there in person to talk with you one-to-one. But you know why that is. We're actually in the medical education command room that we've been meeting every day for the past 7 days, and we're practicing good social distancing. So that's why we're here, and you are where you are, hopefully also practicing social distancing. I want to start by talking a little bit about how I, across the duration of my career, have dealt with a number of different epidemics and crises, because I think it will give you some information that you can perhaps use in the way in which you're focusing on this particular scenario here, this pandemic COVID-19. It is important to recognize that we know how stressful a time this is to be in medical school, and to be particularly in the clinical years in medical school. So it's unusual and it's extraordinary, but it's not an isolated event. I think in the medical profession, all of us get used to the idea that these things are going to happen periodically, and they require a set of competencies that you need to learn and we need to help you master, so that you can be the type of physician who can respond on the front lines, as many of your faculty and colleagues are doing already. So many of you know that I started my career here at UCSF as a resident and chief resident during the HIV epidemic. That was my first epidemic response, but I've had a number of other ones as well that most of you probably aren't aware of. I was an internal medicine residency program director in Washington, D.C., and responsible for the hospital response to the 9/11 attacks on the Pentagon, and then the subsequent anthrax attacks at the post office in D.C. And then I moved to Ohio, and as an education dean and program director there, was responsible for participating in the response to the SARS epidemic, as well as the H1N1 flu. In all of these situations, my job was to protect and support students and residents, and also to personally provide direct care for patients who were at risk of or struggling with the diseases that were in epidemic, or the crises that were facing us. And so I want you to take, when I tell you I know what you're feeling, I do know what you're feeling. I've been where you are before. And I think the learnings I and others of your deans have had will help you, hopefully, and that's what we're intending to share today. Our purpose in holding this meeting is really three things. One is to first provide you with factual information about COVID-19, so that you can know your part in stemming the tide, flattening the epidemiologic curve of this epidemic, by adhering yourself to important public health response strategies. Secondly, we want you to see yourself as informed, trusted ambassadors for the truth. We think that your neighbors, your family, your friends will be yearning for someone that they trust as a good person to help them really understand what's hype and what's truth in the national discourse. And you can be incredibly important to both calm and also activate the community. Calm them when things are wrong, but activate them in terms of getting them on board with social distancing and other public health interventions. And the third thing we want to accomplish today is to talk to you about the changes we've made as a School of Medicine in the educational programs, so that we can do our part as stewards of the public health response for the COVID-19 pandemic, and do our part in flattening that epidemiologic curve that Dr. Davis will talk more about in a few minutes. Thinking about this and thinking back on my experience, I will say that it's fair to say that every day when physicians go to work, They care for patients with infections and accept a certain risk of contagion. It becomes kind of business as usual. And all of you who have been in the hospital know you've taken care of people with multi-drug resistant bacteria, you've taken care of people in respiratory isolation, you've taken care of people with C. difficile colitis, all of which require you to continue to provide care using the best practices in infection control. Epidemics raise concerns, though, about this contagion risk that we voluntarily take on as physicians and physicians in training because of the inherent uncertainty about new pathogens. We don't really know fully what the biologic behavior of this new pathogen is. We have some ideas, but there's still some unanswered question. And we don't currently have a definitive treatment, and we don't have a vaccine that we can use to mitigate some of the risk that providers take and mitigate things like the hepatitis B vaccine or the influenza annual vaccine. And so to me, what this brings into focus is the fact that when we talk about issues of professionalism and concepts like altruism, they're with us every day, but they're kind of in the background. They're kind of an abstract concept that we know guides our decision making, but we don't think about it day in and day out until faced with an epidemic. And then this comes like a laser focus for us. Every day we get up and we put on our clothes to go to work in the hospital and we think to ourselves, wow, I'm walking into a place where we're concerned about patients suffering from a disease that's a pandemic across the world now. And so I think that putting this issue of professionalism right at the forefront adds cognitive burden and emotional burden to the work that we're doing every day. And in my experience in the past, I've dealt with this really understanding the power of community and the power of first getting a lot of information so I know what my risk is and what the risk is to the people around me. And second, talking to my colleagues and then talking again and talking some more, not just to actually share information and brainstorm about solutions, but to also share some of the emotional burden. Because when one person is down, another person can generally step in and lift them up. And I hope you'll be finding that is true with your peers as well as with your deans and with your faculty. So the other thing I thought about in reflecting back to my own experience with past crises and epidemic is that that there's always two questions that physicians and physicians in training are called upon to answer in this. And the first comes from family and friends who basically say something like, I don't know how you do it, or why are you doing it, or why are you as a medical student not just packing up and leaving and going back to school some other time? And the answer that I've come at is truly, I do this because this is the work. This is what I trained for and what you have been training for, and the expertise that you need to develop so that you can be a doctor who can be on the front lines of caring for patients when they need us most and caring for communities when they are most fearful, like in the midst of an epidemic. I think it's important in answering this question, not only to say this is the work, but I feel confident, as you should, that the faculty at UCSF are the best people in the nation and probably in the world for you to be learning from in terms of how to protect yourself and to provide compassionate, patient-centered care for our patients, and to launch and continuously improve system-wide initiatives both at our institution and in our communities to stave off future transmission of this epidemic. The second question doesn't come from outside of you, it comes from inside of you. And that's that voice that sort of, when you get up in the morning and you start to put on your white coat, sort of says, I'm afraid, and what do I do about this? I'm worried, what do I do about this? And again, working with colleagues is super important in this environment and sharing these fears and getting people to talk about. But I also think it's really important to reach down and tap into that empathy that we selected you for, that Dean Wofsy, who was here at one of the earlier town halls, saw in you when you applied to medical school with all of your incredible academic honors, just like everyone else. But we recognized that you had a special spark in serving patients and the communities. And that was why we wanted you to train here with us at the UCSF in the UCSF way. It's important to when you tap into that empathy for others and their fear, that you realize that courage is not just about being fearless. Courage is actually about having fear but acting despite it. And when I feel called upon to do that, I try and look for someone else in the environment who's worse off than me. And in this environment, I think we can say safely that our patients are more fearful than we are, for good reason. They already are fearful about the condition that brought them to the hospital. Some of them will be concerns about COVID-19, but many will be diabetic ketoacidosis or acute myocardial infarctions or asthma exacerbations. And they're already fearful because of the vulnerability that that illness has provided to them. And on top of that, they worry about coming into a healthcare system where they know there may be patients who also are struggling with this pandemic virus. And so think about your ability as a student, the privilege that you have to spend some extra time with patients who are not those struggling with COVID-19, because we do want to protect you from providing direct care for patients with a high suspicion of COVID-19. But there are many others who you can actually spend additional time with, make sure their concerns are addressed, advocate for them on rounds, and in doing so, put aside your fear to sort of alleviate the fears of patients who are probably more vulnerable than you feel at any given moment. The second group I like to sort of think about with real intention, because I think they're often overlooked in situations like this, is the people who are on the front lines and don't have the luxury of being able to work remotely or talk remotely. These are frontline nurses, respiratory therapists, patient care aides, frontline faculty and clinicians, but also the people who make our institution work, the environmental services workers, food services workers, and even the greeters at the front desk of the hospital. And so think too about what it's like to be in their shoes without options. And if you have the opportunity, say a kind word, thank them for what they're doing. And again, try and set aside your fears so that you can work with intention and generosity towards those others. I'm going to turn it over to Dr. Davis now, who's going to talk not only as your curriculum dean, but as a specialist in infectious diseases about the COVID-19 virus. I believe we'll be joined by Dean King at the end of the session, who's currently on a command conversation, but wanted to have the opportunity to talk with you as well. Dr. Davis?
Thank you, Dean Lucy. All right, so one process thing. So we will be able to take questions. If you could add those to the chat window, and especially start them with a question mark. Our dear Do Quinn Tran Taylor has volunteered to take all of your questions and aggregate them and gather them into some common themes, and then we will be able to answer those at the end of the presentation. We will try to get to all of those that we have time for. Our agenda for today is a little bit of a COVID update, and then really thinking about then why do we need to change the curriculum, and what will those changes be, and what can we do to help prepare for that. So as Dean Lucy mentioned, I do occasionally participate in my role as an infectious diseases faculty member here as well. So I thought it might be good to bring at least a little bit of additional information here. We will also be thinking about introducing more about COVID for those who are in career launch into CODA coming up, as well as intro to career launch for those who are just starting career launch, and working into FS and F2 for those who are in F2. So for many of you, though, small flashback to PhD. So coronavirus is one of the causes of the common cold, and there are different types of coronavirus, and some of them are particularly more pathogenic and certainly hit more in the lower respiratory tract. I show a picture of one of those here on the left, which has some of the standard structure of a coronavirus. This is actually from the New England Journal of Medicine in 2003 when we had SARS. And so SARS was also a coronavirus, and in fact, it is very closely related to the current one, which is called SARS coronavirus 2. I show the right picture here, which is from a recent Science article, being able to say that this is a structure of the coronavirus, the coronavirus 2, that is actually bound to its primary receptor to get into human cells, which is the ACE receptor 2. It interacts with a protease domain there. I showed this primarily to just say that there's a lot of science going on. This was done by Chinese researchers early on as the epidemic was unfolding, to say that there are some druggable targets there. People are working really hard to try to make some advances against this pandemic, and there's a reason people are working so hard at this right now, and that's because of its magnitude. So for those who haven't followed, this is the Johns Hopkins website that real-time tracks cases as they are being reported from different municipalities and countries. And in particular, also I will mention, someone did bring up to my attention after the first presentation, there are, by the way, a couple of websites that are screenshotting this and putting this on their websites, like coronavirusmap.com or something, that are actually malware sites, another type of virus. But the idea is that the Hopkins website is safe. And I guess I'll draw your attention here to the number in the upper left, which is 126,000 cases confirmed, and 4,600 deaths in the sort of upper right. This was in the lower left, you'll see this was from 11:30 last night, which is when I was working on this talk. And then as I woke up and checked again at 6:30 this morning, we had already moved to 127.8 thousand total confirmed, so up by about 1,500, and the total deaths had actually gone up by almost 100. And so that's in the span of 8 hours or so. So just giving you a sense of how rapidly this is moving. So this is important. This is an example of a good old epidemiologic curve. And so looking at an outbreak and what actually happens, the blue bars are the curve that pertains to what was happening in China itself. And you can see that the disease there seems to be waning. And that's a great thing, in no small part probably due to all of the measures that were put in place in China, including things like social distancing. And the bars in orange represent what's happening everywhere else. And you can tell there that we do not seem to be going down. And this is current as of yesterday. So what's happening here in the United States? Again, I go to the CDC for most of their numbers to see where we're at. And as most of you who've been following the news are aware, the primary sites of activity and where the disease has really settled is in Washington State, around Seattle, here in California, and in New York. And there are other cases that clearly have been reported, and there is human-to-human transmission going on in those states as well. If we look at our epidemiologic curve in the United States, it looks more like this. Do not be fooled by what you see after that sort of March 2nd or 3rd point there. As the graph illustrates, these are illnesses that began probably prior to this or after this time reported, that they began before but haven't been reported, and we will likely catch up with this over time. So what do we know about the disease in terms of some of its effects and some of the other epidemiology? Much of what we know comes from the reporting that we had in China, where they have had extensive experience with the disease. And so I'm showing a few graphs of this, also generated primarily by Johns Hopkins. Looking first at what is the spectrum of infection itself. And luckily, the majority of infections are mild. Again, 80% or so are mild, only about 5% requiring intensive care. The bulk of people recover, so that's another good sign. Again, the 3.5% who don't, we'll get to in a second. In terms of risk factors for bad outcomes, so for people who die, the mortality rate is actually much higher for those who are advanced in age. So clearly elevated for those who are over 60, over 70, or over 80. and those with existing conditions. So you note here specifically cardiovascular disease, diabetes, and chronic respiratory disease as examples of predisposing conditions for mortality. How contagious and deadly is this? So if we put that in that kind of 2 by 2, so on the left is a graph where on the x-axis you have the average number of people infected by each sick person. That's an R value there, and that speaks to how contagious a virus is. And on the y-axis is the percent who die, the case fatality rate. And so if you look at this, COVID-19 or the SARS coronavirus 2 is not surprisingly not far from the original SARS, you can see there, and from the Spanish flu itself. So you can see it lies within that box. And there's an error bar there. So on the right, that's because the case fatality rate actually depends on the country. So again, in China, where there has been a lot of experience here, the case fatality rate seems to be around 3.9%. In Italy, which is currently having a huge outbreak, the case fatality rate is up to 6.2%. Here in the United States, it seems to be closer to the number found in China, which is for us 3.1%. But you can see again there, depending on the number of cases, the fatality rates have changed dramatically. I mentioned Italy, and for those who have not had a chance to see what's going on there, I would strongly encourage you to do some reading about that to see where things could be going. In particular, this is an article that was posted yesterday by one of the writers in The Atlantic, who is actually a medical ethicist and is stationed in Italy and witnessing a lot of what's going on there. Italy had gone within the span of 3 weeks from 200 serious cases to 2,000 to now over 12,000, and in particular, it really is overwhelming their healthcare system, especially ICU beds, ventilators, et cetera, and people are making very, very difficult decisions about triaging. And so I found that the close of the article and the exhortation was really important, asking all of us here in the States, the political leaders, heads of business and private associations, and every one of us to work together to accomplish 2 things: to radically expand the capacity of the country's intensive care units and to start engaging in extreme forms of social distancing. Cancel everything now. The emphasis is the authors. So that gets us to a little bit of why change and why do we need to do some of this. Again, going back to what is now all over the internet, Twitter, I'm sure it's its own meme, is the concept of the flattening of the epidemiologic curve. So on the left is the standard model in red, the usual epidemiologic curve. You see an incidence, or you see a number of cases being reported in a given time period, and that rises and then eventually falls as the outbreak ends. And if we institute mechanisms that decrease the forward transmission of infection, something like social distancing, that can flatten the curve, and that's shown in green, which means that that the number of cases being reported in any one given period of time is lower than if it had been left to its own devices. As a consequence, that actually can also extend the time period over which an infection can happen. There also is, as shown here in blue, the concept that if one lifts interventions, such as removes social distancing, there can be a resurgence. And these are not just theoretical concepts. Shown on the right are actual epidemiologic curves related to social distancing interventions here in the United States during the Spanish flu in 1918. And if we look at Philadelphia, where there was a delay of around 5 months or so before social distancing was employed, you see sort of the standard peak. Whereas if you look in St. Louis, where these social distancing measures were taken immediately, you see that same concept of flattening of that particular curve. So, and why is that important? Again, it's not the area under the curve that's actually most important. What's most important is this blue line here, the concept that the number of cases that comes out in a day, which is in theory directly proportional to the number of severe cases that you would get in a day, really can run up against the capacity of the healthcare system. And if you exceed the capacity of the healthcare system, that's when you get to see things like what's happening in Italy right now. And so, so really our goal is to do everything we can to ensure that we do not overwhelm the healthcare system, because that's when we're going to have to make some really, really tough choices. So summarizing, why change? Number one, this is a serious disease. Number two, we are all at risk of infection. Understanding full well that we may have different risks of complications from this infection, and for some, those risks are much lower, but we are all at risk of infection and therefore at risk of passing this forward. And so for the safety of ourselves, each other, and for the greater community, we should, each and every one of us, do what we can to stop the forward transmission of infection. And our individual and collective adherence to these kinds of measures can make a difference. So I mentioned an R factor before, and not to get too ID nerdy, but it's pretty nerdy.
Pretty nerdy,
okay,
yeah.
pretty nerdy. But that R number I talked about, that reproductive number, we know is influenced by different discrete factors, including things like the number of contacts per day. The more people you're in contact with, if you are infectious, the more infections that can happen. That's where social distancing, self-quarantine come into play. At the same time, the probability of transmitting an infection per contact is a factor here, and that's why in the hospital we do things like wearing our personal protective equipment, or PPE. We wash our hands, because that decreases the chances that for any given contact that we will transmit the infection. There's also the infectious period that's a factor here, and we can do things there like contact tracing to decrease a latent period, or starting timely treatment when treatment is available. And then there's population susceptibility. So our goal, of course, is to reduce population susceptibility, and vaccination would be a great way to do that. So those are important concepts there, and we can make a difference by affecting that R number. So back to the curricular domain, what are the changes going to be? And I'm sure many people have reached email fatigue. There have been a lot of emails that have been going around, and we have certainly contributed to some of that. I do hope that you get a chance to read the emails that we're sending. There are some concepts contained within that, and I will try to summarize as best I can what's happening here. So effective Monday, this coming Monday, March 16th, all classroom and lab-based instruction will move to remote or distance learning for all phases. Our patients and members of the public, including things like standardized patients, who are on campus really only for our educational purposes, that has been suspended. Again, because we can't really justify exposing patients and members of the public to a possible increased risk by coming to a health system when they have no other reason except for our education. Essential activities, so things like secured exams. So that includes, for those who are on in F2, shelf exams and the like, will still be happening on campus, and that is permitted for groups less than 25. Clinical activities, again, for those of you on F2 and career launch, clinical activities remain there because you are essential members of those clinical teams. You are providing care. You will have the ability, in fact, to provide some types of care that members of your team will not be able to while they are tending to other things. It's important to know that campus will remain open. So though we are making these changes, the curriculum is not shutting down, the campus is not shutting down. The curriculum continues, campus will remain open, resources are available, extracurricular activities that are organized here will be suspended. And then what can we do? So first is preparing for remote learning. So there will be some things that you will be doing remotely, and many of you have been doing remote learning. Obviously, A lot of people are used to seeing online lectures and things of that nature. We will be trying some new things, not just online lectures. There may be more Zoom meetings, especially for small groups and things of that nature. So just making sure that technology is up to date and reliable. When you're having an important Zoom meeting is not the time to find out that wherever you're at, that the internet is not as robust as you might hope. Practicing or dry running sessions first. Remember that remote learning in general can be more flexible, but as many of you have probably experienced when watching online videos, it can be more time consuming. Not everyone absorbs information quite the same way, and that may not be the easiest way for some. And so it can be more time consuming. Remembering that process during meetings, especially online when you're having a Zoom meeting, is incredibly important. I'm sure many people have seen the YouTube videos and whatnot about the conference calls and things of that nature. So again, just focusing on process. At a time like this, especially in F1, but I think for everyone, when there is an increased amount of activity that is happening remotely and you're doing more social distancing, it can be a little isolating. So I would ask that you invest a little extra time in the check-in when you're doing that with your small groups. Just check on each other, see how everyone's doing. It's good to connect with people, and again, Zoom is not always the optimal way to connect, but it's what we do have in some ways now, and so I would encourage you to lean into that. And then take advantage of virtual office hours, Q&A sessions, things of that nature. Again, most non-essential meetings have been moved to Zoom type meetings, and so taking advantage of virtual office hours or other things is a really good idea. And then I had here, I just want to share some information for those who were in F2. So FS and F2, which already had remote capabilities, will now move to remote again. So there will not be an in-person attendance option for that. Clerkship didactics are in between. So we are going to give clerkship directors the opportunity to, if they have very small groups and have the ability to ensure that social distancing is appropriate, and just so everyone is grounded in the same definitions here, we are defining social distancing as basically arms width apart or approximately 6 feet apart from each other. And that's based on the fact that that this coronavirus, like many others, is spread primarily by droplets, and those typically travel about a 3-foot radius around us. So, so 6 feet is considered to be pretty much more safe. And so, so if they can ensure that and ensure that the premises are appropriately cleaned, et cetera, and up to CDC standards, then they can proceed with their clerkship didactics. I will tell you all now that that we may have to migrate to remote and or other pre-recorded sessions, because if this pandemic continues to progress and take more time and effort from our faculty, they may be pulled to give time primarily to patient care. So we will have to be flexible with that. And a reminder to everyone here that you are not to be providing direct care for patients with known or suspected COVID-19. For the career launch students, again, I think we primarily have 4B students here for those who are oh so close to graduation. There may be some 4A students here, but for those who are 4B, remember that we will work with you if sites close on short notice. So there are some sites already that have been overwhelmed by the number of patients presenting with respiratory disease and have even started running short on personal protective equipment. And so they have actually requested that no learners be in their environment. And so, and that can be on incredibly short notice. So we will appreciate your flexibility up front, and we will work with you. The primary goal here is so that your graduation is not in jeopardy. And so we will work very hard on that. And I would ask that, that you please be in touch on email, including even after match day, for updates not only about match, but other events that are happening as well. We will have to take those as it goes. For right now, we are planning about a 1-month period out. And so we're updating that every week or two to see where we're at. And again, as many of you who have been following the news have seen, things can change really on a daily basis. So at this point, I will hand things over to Dean Lucy to make some more closing comments. And then we will see if we can hear if Dean King is around.
Yeah, I'm going to turn it over to Dean King and just make one observation that I think is helpful to think about as you're talking with your friends and family and colleagues. The way we manage risk in the community in terms of infection is through social distancing. So not only being 3 to 6 feet away from everyone, but also minimizing your participation in big crowds, staying away from anyone who's sick. The way we manage infectious and contagion risk in the clinical environment is through infection control. And so it's obviously, when you think about it, there's no way that you can be 3 feet away from a patient you're taking care of, regardless of what the illness is that they have that has landed them in the hospital or in the clinic. So just be aware that that as clinical students, you are living in 2 different environments, one where social distancing is the way to go, and the other where decreasing risk through infection control is the right way to do things. And so with that, I'm going to invite Dean King.
Hold on, sorry. Sam's going to help Dean King right now, so if you could do your part. So I'll give us a few minutes.
Sam is going to apparently help Dean King now.
Yeah.
So we will switch to the Q&A.
Right, so
I just will make a couple, just two
yes,
quick comments.
Please.
One is we are very committed to making sure that your curriculum continues in the way that it needs to continue so that you develop the competencies we need you to have to be UCSF physicians. That being said, this is actually a situation where we will expect that there will be some glitches, and we hope that everyone can understand people are working as hard as they can. They're your faculty, your direct course directors, the staff, clerkship directors. So be a little bit forgiving and patient with us. We'll get it right. Please give us advice if you find some things that you think could be better. The other thing I want you to realize is that the faculty who are teaching you are also working hard to keep our health systems functioning. There's an incredible surge of patients, and we expect there will be more. So they're either actually providing care for patients themselves and extra patients in that, or working to redesign our local institutional systems or our public health systems. You may have seen some of them even on CNN and many of the media shows, and working in the government. So if you have the opportunity and the inclination, acknowledging that this is a hard time for them, that they're working hard, and you appreciate their engagement with you would be, I think, really priceless in terms of helping manage their morale. It's not your primary responsibility, but if you have the time and effort to do that, I think it would go a long way. Everyone needs to be supported in situations like this, and the faculty are no different. And then lastly, as I said earlier, this is an expected part of being a physician. It doesn't mean it's easy. So if you need some extra support, please reach out to us through either email or through the Student Experience Hotline. Contact us by email if you have concerns or ideas. Don't hesitate to let us know what questions you have, what support you need, and what thoughts you have about how helping us and the others in the environment do the very best job we can with your education. So with that, I'm going to turn it over to DQ. Is she ready to do some questions for us, or is Sam?
I think Talmadge Dean King might be ready now.
Okay.
I think we should go to the questions that are online. I can see many of them. I just wanted to add a couple comments in a way similar to Catherine. It turns out I'm in that high risk group, so that means I'm old, and I've been in medicine for a long time. And my early part of my career, I spent working with drug-resistant TB, which is spread basically very similar to the way this virus is spread. One of the experiences I had in the 20 years I worked there was that none of the healthcare workers, in the 20 years I was there, 2 healthcare workers got sick from tuberculosis. This is what I was working with, drug-resistant TB. And the reason they got sick is because they absolutely broke protocol, and they were involved in the patients in ways that was inappropriate. But everybody else who actually did what they're supposed to do never contracted the disease. And in fact, my wife was a high school teacher, and she converted her PPD, and thankfully, in all this time, I never did. And her exposure was to someone she didn't know had TB in her class, and because I was working with TB and knowing it and expecting it and doing all of the right things, I think I was fortunate to protect myself from that. So my message to you is, this is a serious problem. You have to now take it seriously. It may at times not feel that way, but as a medical expert, you should take it seriously. You should not panic, because panic is not useful. And how do you get it? People cough, people speaking to you directly, they sneeze on you, they spit on you, they laugh within your barrier, or they sing, for example. Those are examples of how airborne droplets are made airborne, and the virus is in those airborne droplets. For most part, those droplets will fall to the ground. So if you stay 3 to 6 feet away, certainly 6 feet away, there's virtually little chance, except if you touch something now that someone has sneezed on, and you put your hand to your face or mouth, you can get it. So practicing really good hygiene, taking this very seriously, and teaching others in your community to do it, I think is important. The other thing that I want to reiterate is, if you get sick, you are sick, and you should assume you're infected until proven otherwise. And we'll talk later about testing. We are now beginning in the next day or so. We will ramp up. We're capable of ramping up to do a lot more testing. The testing will be done on the people who have the highest risk, but I think pretty soon we'll be able to test more and more people, so that if you have any symptoms, you will be able to get a test within a day or so to prove whether you have it or not. And the symptoms are fever and dry cough and fatigue. You usually don't get everything, but those things should actually make you worry that you may have it, and you should just assume you do until it's proven otherwise. So anyway, I think that we are here to help you. We realize that this is challenging, and we should stay in as few locations as possible. The social distancing is really important in places where it's done rigorously. The epidemic has diminished. So take that part seriously. But thank you all for all that you're doing. I know that this is trying. This is a moving target. We're working as rapidly as we can to address all your questions, concerns, and make sure that your education continues. But thank you to Dean Lucy and Dean Davis and the other people who have been working day and night to try to make sure that we do the best we can.
Thank you to Dean Lucy and to Dean King for being here and for comments. And again, thank you to all of you for your patience, for everything in these sort of uncertain times. And remember, we're here. Reach out to us and let us know if there are questions or if there are things we can do.